All right, I think we're going to go ahead and get started. And I see that we are recording. My name is Dr. Martha Sajadovic. I'm a health services researcher from University Hospitals of Cleveland. I'm delighted to invite everybody to our uh, Distinguished Speaker Series from our Health Services Research Center talks. I want to mention a few housekeeping notes that this webinar is being recorded and will be available to view from the UH Research and Education Institute website. I'd like you to please mute your microscopes too, I guess, throughout the presentation. If you need technical assistance, please contact our R&E team. Nicole Bollinger and I think Abigail Zona are both on the call, so please reach out to them. If you want to ask questions, you can type them into the chat. Questions will be seen by all attendees, and you'll have the option to submit them anonymously if you prefer. For those of you who are invited to the meet and greet session after the presentation is done, please remain on the Zoom after the completion of the Q&A part. And I think we've got Catherine Coyne is there, Katie Coyne, Susan Masanek, and Jennifer Levin, I think, are all on the call. So great, you're here already. It is my great pleasure to introduce Dr. Mark Holmes, PhD. He's the Thomas W. Lambeth Distinguished Chair of Public Policy at UNC Gilling School of Global Public Health. He also serves as the director of the Cecil G. Shep Centers for Health Services Research. Dr. Holmes's work focuses on rural health, healthcare access, and the financial sustainability of healthcare providers. With a keen interest in how geographic and policy factors shape healthcare systems, Dr. Holmes has contributed significantly to the field through research on hospital closures, research health disparities, and innovative healthcare delivery models. He will be speaking about what does the future hold for rural hospitals. I know that's a topic I'm very interested in, and I'm sure is of wide interest as well. So, Dr. Holmes, I'm going to turn it over to you. Thank you for your willingness to present to our team.
Thank you, Dr. Sajadovic, and I'm excited to present here today. My disclaimer, there's no federal funds that were used to support this research, although it's drawing from previous research that was federally funded. So just mention that. So what I'll talk about today, and I have a colleague who likes to do this so that you can read this and completely check out and update your MySpace page or whatever. But in terms of a talk of one slide, some of this, probably rural communities have lower access to healthcare. That's probably not a surprise, but like, it's interesting to think about that and how that plays into what I'll talk about for the rest of it. Talk about the financial stress that rural providers, particularly hospitals, have been under in the last, 5 decades, but notably the last few years. Some notable trends in rural healthcare delivery that may impact access, and then one last slide that looks at what's next, and there's a lot of uncertainty around that. So every time that I give a talk like this, I like to start off talking about rural. And if you spent some time in rural health research, you know that you can pretty quickly get lost into a quagmire of how do we define rural and what does rural mean here and what does it mean there. And we could spend hours on this. For the most part, most findings are essentially the same across these different definitions, and whether you use metropolitan status at the county level, or if you're using RUCA codes at the census tract level, or using census urbanized areas, or different measures at the county level, they all pretty much tell the same story. So as I'm going through this, I'm not going to spend a lot of time arguing about which definition I'm using here or there, because for the most part, everything here is driven more by what are the data available at rather than what is the concept of reality we're trying to get at here. Is it isolation? Is it critical mass of population? Is it some measure of connectedness to larger facilities or larger communities? Each of those may have different impacts. So rural residents have lower access to care, and we all know the 5 A's of access that we sort of can be thinking about. And this is all relevant for rural health. We tend to focus on things like availability and accessibility when we're talking about rural, because rural has a spatial element to it. But there's others, of course, that are going to really matter here. From affordability, rural areas in general have lower income and more uninsured, more public insurance, less private insurance. Accommodation, wait times, clinic hours, flexibility, for example. And I'm thinking about the ability to do telehealth. And we know that we've seen prior to the pandemic, telehealth and the telehealth that existed was predominantly used by rural residents more than urban. And then during the pandemic, it flipped. And now post-pandemic or peri-pandemic, I guess post-pandemic now probably, we're seeing telehealth higher among urban residents than rural. And so that's just an example of that. And then acceptability in terms of cultural, linguistic, and personal preferences. Cultural may be important there too when we're talking about rural, and how rural residents want to engage with the healthcare system may differ from how urban residents do. So just some examples. Here's a chart that shows the percent of residents in a county that are within 15 miles of a hospital. And the darker the color, the lower the rate. And so often we present these as sort of like dots kind of thing. But it really, I like this measure better because it accounts more for cross-border traveling, the ability to cross county borders to seek care, but also the nature of the county. Where is the population concentrated? And we could see places like sort of Big Ten country, where y'all are from, Ohio, Indiana, with those really light blues going into southern Wisconsin and Minnesota and even Iowa, with that lower rate, better access to hospitals, whereas in the Mountain West, unsurprisingly, more isolated and more distal from hospital healthcare. Here's a chart that shows the primary care or physicians per capita. The legend isn't super great to see here. This is from a JAMA paper a couple years ago. But you can probably tell that the black lines here are rural, and then the seafoam green and sunset orange colors are different measures of urban. And you could see the wide variety there, and the large disparities. And even among the primary care, it's a growing disparity there, and certainly more so for the medical specialty and other specialties as well. And the punchline here is it's not gotten any better. This is using 2021 data from the ARF. And if we think of metropolitan, micropolitan, and then non-core, this neither, we often define rural based on the residual. And so that's how it's done here. 7 times more specialists per capita, and 78% more primary care per capita in urban relative to non-core. A recent study looked at ambulance deserts, and again, a similar story with that Ohio, Indiana, Illinois, Iowa ban there, and even going into Michigan, where I'm originally from. You could see pretty good access to ambulance in terms of the percent living in a desert, but some of those darker colors representing, again, more distal from emergency medical services, and thinking about the impact that has on outcomes. And certainly, this would be an example of a motor vehicle mortality. We like to call this the lollipop charts, where the dark green dots are rural and the light blue dots are urban. And you can see, I'm pretty sure it's every single state, the rural rate for motor vehicle mortality is higher than the rural rate. And that's unsurprising when, provided the EMS distance to hospitals, and also baseline factors that we think, like epidemiologists here, about roads being faster and curvier in rural areas often. So, but just an example of how access to healthcare can have outcome effects. Okay. All right, part 2. Rural providers have been under considerable financial stress, and it's unlikely to end soon. So we'll focus primarily here on hospital profitability, and I'm going to talk about 2 kinds of hospital margins. Patient margin, which we might think of as the profit from patient care. And I got profits in quotes because we're going to include not-for-profits and government hospitals who don't have a profit, but we might say excess revenue. And then total margin is the same measure, but includes all revenue and costs. So investment income, any government appropriations, your revenue from the gift shop and the parking deck, for example. So patient really is like your core business, and then total is the overall enterprise. Both are important, and are telling slightly different stories here, as we'll see in a moment. All right, there we go. Okay, so walking you through this chart originally. So this is starting in, I think, mid 2011 up through the first red line is March 1, 2020, which is a convenient way to mark the beginning of the global pandemic from coronavirus. These lines represent the patient margin, and is a moving average based on the fiscal year closure. And so green represents the rural, blue represents the urban. So if we start from the top, the average urban hospital had a 1 to 2% typically profit margin on patient business. So it's core based business. It was making 1 to 2% on. Not great, but sustainable. Meanwhile, if you look at the average rural hospital, a 5% negative loss at the beginning of the decade, and decreasing throughout up until the start of the pandemic, average typically being about a negative 6%. So two things to take away from there: rural is lower, and if you look at it, they look like those lines are separating, and indeed the gap is growing. Then every state had something like this. This was North Carolina's, that has this memo that says beginning March 23rd, in this case, stay away from hospitals effectively. Not quite that blunt, but all elective and non-urgent procedures and surgeries are suspended. About this time, I was working in my garden, and the way that I tend to do chores around the house is I toss on some slippers and I go and get the paper, and then I take the trash cans in and I slowly escalate. And for however it happened, I was gardening in my slippers and was using one of those green stakes to mark to guard from the deer. And surprisingly, the slipper didn't hold up very well. Made a nice gash in my foot. This was April 10th, I think, or Easter. And I should have gone to the ED, but I said, well, I know I'm not supposed to go currently. So I treated it at home like basically like a battlefield injury. And this happened over and over again, right? People were avoiding getting the health care that typically they would have a month ago or 2 months ago, but stayed away. So what happened? Margins plummeted. People stayed away. Revenue just completely fell off the chart. And costs, meanwhile, were skyrocketing due to all the PPE that had to be secured, all the rapidly increasing labor expense. This is about the time when traveling nurses were really big, and so you have these hospitals getting completely crushed in terms of their ability to have a sustainable core business in patient care. But and then what happened, and then after that, slowly recover. But what's interesting here, and I haven't really spent a lot of time thinking into, is that first part up through March 2022 is as expected. It basically returned to where we were. I don't know why we've gone back down since then, which raises some questions and I think further inquiry. But one way to view this is that, well, for the most part, they've recovered, but maybe that's a transient recovery, and there's something longer term here that represents a lower level, which is something to keep an eye on. All right. Getting that arrow perfect. Okay, so that's patient margin. Let's add the total margin now. So this is the overall financial health of the institution. And these are positive. On average, these are positive. That's good. We can see that urban hospital being up there at the 6%. Pretty good if what we're looking for in a total margin. Rural, smaller, but positive. Again, that's better. And these are generally maybe deviating a little bit, but much more. We're not seeing the same level of divergence as we saw on the patient side. Pretty flat, not much trend either way prior to the pandemic. All right, what happened then? Well, Congress recognized, and the dip in the patient margin was probably one of the easiest, most predictable events that we'll ever see in terms of effects on healthcare providers. And so Congress stepped up and said, all right, we're going to deliver a variety of financial supports to hospitals. And through the CARES Act and through PPP and Provider Relief Fund, a variety of programs helped shore up the finances. But we have to recognize that rural started off from a weaker standpoint. And so in recognition of that and the poor ability to weather the pandemic, there were a variety of special targeted provisions for rural hospitals. You can see there, if we look at the general distribution, the funding was roughly proportionate to their operating expenses. The average, or the funding was 2% of total urban operating expenses, and for rural hospitals is about 1.9%. Pretty proportionate. Then, when you added in a rural specific funding, and there were other safety net and tribal components put into that, urban goes up to 3.3%, but rural went up to 11%. And then following through even more to the high impact distribution. And we end up seeing here that as a proportion of their expenses, rural hospitals got roughly double the support from federal subsidies and supports during the pandemic that rural did. So what do we think happened? Well, sure enough, we saw total margins really increase pretty dramatically during the pandemic. And we see that even for a little bit there, rural was above urban, but then they both started recovering. And there was a period in about this point here at the peak of the total margins where there was a lot of um, review and commenting that getting these hospitals up here, maybe this money wasn't well, was over supported, for example. But what it turned out is a lot of that was just the timing of when the reporting. The revenues were reported in some cases after the expenses, some cases before, but they didn't always align. And then we saw them again. You can look at the rural, goes back to the pre-pandemic level, and urban again is lower than where it started from. Potentially some recovery there, but still interesting there that being for a moment they're lower than where it started pre-pandemic. So what we've learned from that, right, is that rural margins were lower than urban. Were in both cases having some divergence pre-pandemic. The average rural hospital is losing money on its core business of healthcare. The supports were critical to keeping the hospitals open. And then post-pandemic, they've stabilized, but potentially urban are still recovering. And we saw a little bit of that stuff on the far right-hand side, which also could be a statistical artifact of the moving average of that end of the period as well. So not a lot to draw from that yet, but still interesting and worthy of keeping an eye on. Okay, so that's where we've, that's sort of what's been happening. Well, what's that mean for the broader context? Well, we spend a lot of our time tracking rural hospital closures, and we've got this nifty little website here with a bunch of dots that tracks effectively. The way to think of this is communities that have lost their hospital. Blue dots meaning in that one that's been lost in the tens, yellow dots since 2010. And you can look at this and see some patterns here. Part of this, of course, is the denominator need to be considered, but a lot of these dots are happening in the South. If you look carefully, you can see that Arkansas and Louisiana don't have a lot of yellow dots. Those are two southern states that did expand Medicaid, which there's been a lot of commenting on. Kentucky, similar boat to some extent. But overall, you can sort of see where these hospital closures are occurring. Nationwide, 152 since 2010. And that's an undercount for reason I'll say in just a second here. Now, what does that mean? So when a rural hospital closes, I'd say surprisingly, but we don't have evidence on the most direct effect of a hospital closure in terms of mortality. And part of this is almost surely due to small numbers when you think about how many deaths could be avoided if a hospital were to remain open. It is likely sizable, but statistically the power has got to be pretty small when we think about what we're trying to do here. So that remains elusive. I often have a parachute in this slide showing that we've never really shown that parachutes are effective using a randomized trial, but I think everyone expects that they are, even without the gold standard of scientific evidence. But we do know some things. We've seen that, for example, when a community, I think these were zip codes, experiencing a hospital closure, they're seeing, somewhere between 2.5 to 4.5 minute longer EMS of scene to hospital time. So going from the pickup of the patient to ultimately the care. And again, 2 to 4 minutes doesn't sound overwhelmingly bad. I made that joke to my wife when she was in labor. It did not go very well. And imagine if you're in severe trauma from motor vehicle or stroke, golden hour, 2 to 4 minutes can be critical. We do know that there are more admissions for preventable conditions and fewer for emergency conditions. We're going to break this into two pieces. This was work led by someone out of the CDC, and they looked at hospitals or communities that saw a hospital close, and then they tracked what was the hospital care like for those people post closure, and the preventable admissions went up. So these are things like complications from diabetes, dehydration, things that we would like to see treated in an outpatient basis. When a hospital closes, it's easy to see the inpatient side close. We also know the ED probably goes away, and there's also going to be some outpatient services there, maybe a clinic, maybe some hospital-based care. So that's sort of predictable. The fewer for emergency conditions was kind of an interesting one. And so if I live in a county, my hospital closes, I ultimately have fewer admissions at other more distant hospitals for emergency conditions, things like stroke, for example. And the one way to reconcile that is that they are not being admitted, that they're expiring before they get to the ED or the admission. So that's one way to sort of think about that. ED visits at nearby hospitals are increasing, but lower ED and outpatient use by the affected communities. And so that fourth bullet, we can think of this as avoided care, things that me in the garden. I probably should go. When it was 5 minutes away, I probably would have gone up. But if I have to go 30 minutes away, I'll let it pass and I'll use I think I use duct tape and kind of just make it work. So all those fit together to tell a story of the closures, meaning longer distance to travel, lower use. We know that people value time, and sometimes they're going to lead to a more acute presentation. The other piece I think is really important to be thinking about when we talk about rural hospital closures is the non-health effects. And I got two examples here. Certainly, there's a full bullet on economic effects. We've done some work here, and others have as well, showing that per capita income decreases. The average rural hospital employs about 150 people directly. Then you think about all the other people whose jobs depend on it. The groundskeeper, for example, the florist shop across the way, all those things that are services that are contracted for. That's a lot of jobs being lost from a community of, these counties typically have 40,000 people. So 150 divided by 40,000 isn't small, but when you think about that, these are generally going to be pretty good jobs, all the other things that stable with it. And how many people move away? We see the population decreases, partly because of the direct employment, people saying, if you're a physician and the hospital closes, or if you're a nurse who specializes in inpatient care or a rehab therapist, you could commute to something 30 minutes away. You also could move and just find a new job. But then also, what that means from the health of the community. So we've been tracking closures. We often get the question, are you tracking openings? And one year we looked in particular to see how many are there. I think this was 2017 or 2018. We found two. Both were launched with great fanfare by the community, including the mayor in both cases stood up at the press conference and talked about how important this is for our economic development strategy of affluent retirees. And both of these communities were launching this big development of 55 plus kind of people or residents, and having proximate access to healthcare being important for that. And then I like this other side here. This is I didn't cite it, so I have to go back and do that. A case study here where they did some qualitative interviews. And here it says economically and socially, it was the center of the community. And we did some work in the Appalachian region to look at communities that were healthier than they should have been based on their social demographic and economic profile, and did case studies on them. In I think 17 of the 20 counties, there was a hospital that served as the core, the nexus, everything from the catalyst for community-driven things. And if there have been 3 drunk driving deaths this past year, we need to get together and do something. The hospital would stand up and say, well, use our boardroom. Let's meet Tuesday nights. We can dedicate half a staffer to keeping this thing going, and we'll buy the food. And serving as that social nexus, and sponsoring the softball team, all those kinds of things that hospitals and major employers do. Okay. All right. So we've talked about closures and what those mean. So what are we seeing in terms of changes in the rural health service provision landscape? So four points I want to talk about in particular is the rural emergency hospital, the way that rural hospitals are delivering inpatient care, systemization, and the maybe systematization, I don't know, but the notion of hospitals becoming part of a system, and the disappearance of the independent rural hospital, and then service provision. So a couple years ago, as part of the Consolidated Appropriations Act, this new provider type was rolled out, the Rural Emergency Hospital. And the way to think about these are take a rural hospital and close the inpatient side. That's the mental model. Um, CMS and Medicare requires a hospital to have an inpatient service, and so anyone that doesn't have that is no longer a hospital. And the direct impact on that is losing the facility fee for ED, for example. And so it remains very financially challenging to operate an ED if you are not a qualifying hospital in most cases. There was a hospital near us a couple years ago that said, we're going to try not to admit people anymore. They would not close their inpatient unit because they had to keep open for this, but their average daily census was like 0.05. They admitted, I think, 4 people a year kind of thing, so that they could keep the facility fee going. So these REHs, no inpatient side, you can have an observation bed is fine. Has to have a fully staffed ED 24/7. Other services can be provided, largely paid on Medicare fee for service, with a plus. Outpatient is based on 105% of the fee schedule. And the sweetener is what made these possible, is this additional facility payment of what ended up being just under 3 million this past year. So um, call that a fixed payment. Some people like to call it a grant. I don't think grant is appropriate word for it. It is part of Medicare's buy-in for it. So this fixed payment. And so that helps them. There are rules on what they can spend that on, but that helps them make the transition. Like, again, if you're a hospital that was having ADC of 1 to 2 per night in the inpatient side, um, closing that and cutting some costs from that inpatient side meant you took a hit on the ED side, but this AFP helped make up for it. Where are these popping up? 30, these are the 36 of them. There's a 37th one that's been approved, but hasn't been announced yet. But 30 of the 36 are within that red circle. So definitely sort of like a South Central, centered in that East Texas through up through maybe West Kentucky kind of bit there. And you can see where those are tending to pop up. These are generally hospitals that had a very low ED census, extremely low inpatient census of 1 to 2. I think for the most part, less than 3, with one exception per year per day. We also know that rural residents are increasingly receiving inpatient care from urban hospitals. And so we saw acute average daily census at rural hospitals fall 13% from 2011 to 2017, with not much change in urban. And what the driver of this is an increasing tendency of rural residents to be admitted to urban. So, we use the term bypass, but not going to the local hospital, going to an urban one. And so we're seeing rural hospitals really seeing a larger decrease on their inpatient side, which is part of the prior slide, right? Making it more feasible to close that inpatient when we're seeing this happen. So as they're doing that, what happens? Service erosion, labor and delivery being one of the service that probably gets the most attention nationwide, but chemotherapy, oncologic services, other services disappearing or being closed in rural hospitals, partly in recognition of this, partly because of payment structure in terms of thinking about alternative payment models, creating incentives for uh, the large AMC, or more generally the flagship hospital, the core of the system. If we know volume drives quality, having more control at the flagship, taking some of those services out of rural hospitals, concentrating them, and maybe adjusting how services are delivered in the across the system. And then finally, changes in like what is delivered now, knees being outpatient, whereas years ago would be much longer, changing what you get admitted for and how long you stay, having implications at the rural level. In North Carolina, for example, we're seeing near capacity. Many of our urban hospitals are near capacity on a daily basis. A lot of excess capacity at rural hospitals. So, certificate of need allocating beds in those large urbanized areas, even though there's unused in the rural because it's hard to export a hospital bed. Increasing concentration is part of being a part of a system. The green dot being rural hospitals, what percent are part of a system? Black being urban hospitals, both are increasing, both increased by double digits with a larger increase in rural. North Carolina in particular, I think we're down to 3 independent rural hospitals last I saw of our 120. So again, this is largely regional in terms of how it works, in that once a couple systems start affiliating and acquiring rural hospitals, there being a strategic dash to add to the system. Mentioned service cutting. I call this chart the sorry chart. If you played the game Sorry as a child, you land on the arrow and then you slide and then you kick your sister back to home and you say sorry, even though you're not really sorry. That's the way to read this chart. You start from the bar and then you go along the line to the circle. The red dots are those that where we're seeing decreases the red lines are decreases. Green are the rural hospitals, and so we're seeing declines there in labor and delivery and obstetrics, as we've seen, as we've talked about before, but then also skilled nursing here. I mentioned chemotherapy, but that's wrong. It's really skilled nursing. The American Hospital Association did this wonderful task force in 2016 to really take a holistic view of what does each community need, and they defined essential healthcare services. Those are the columns, and there are 8, if I can count that fast, 9 different services that this task force thought each community should have. So primary care, psychiatric and substance use treatment, ED and OBS care, prenatal care, transportation, and you can see the rest there. I do want to point out that the maternity section is prenatal care, not labor and delivery. So this task force recognized that labor and delivery, they believed, was not an essential healthcare service, in the sense that it may not be feasible financially for every community to have labor and delivery, but you should have access to prenatal care. And this is interesting. I like to think of this as like a lens by which to view community service profiles. And then they organize by the rows what the strategies might be to address those. So global budget payments, urgent care center, virtual care strategies. And I think this is always an interesting lens if you're working in rural healthcare, particularly case studies, keeping an eye on this and thinking about, this community, what does it have among these essentials? What does it not have? And if we want to think about, for example, addressing transportation, which of these rows should we be thinking about more that would be more critical? All right, finally, what's coming with a question mark here. I've got, this is what ChatGPT just tried to describe myself. ChatGPT always makes me far more handsome than I think is fine, but that's only one of the reasons that generative AI hallucinates. But this is supposed to be me looking into a cracked fortune or crystal ball. No one knows what's going to happen, right? There's a lot of prognostication about what might be coming over the next 3 months to 3 years, whatever. But these are some potential things that have been sort of discussed. Lots of potential changes to Medicaid. If you've been following along, you know that the budget reconciliation has for $800 billion in savings for Medicaid. We do know that rural populations are more dependent on Medicaid, particularly kids and adults. A larger percent of children and adults are covered through Medicaid than urban. Evidence has shown that expansion has decreased rural hospital closures. Um, we may see more targeted support, so using Medicaid, for example, to support labor and delivery or residency programs for physician training. We've seen Medicare Advantage growing in rural areas. There's mixed evidence on the effect of that, but if you ask rural hospital CEOs, that's their number one threat that they state. And then in terms of market reforms, you know, likely to be less antitrust review of plans and system. Even though certificate of needs are a state initiative, those are probably likely to continue to decline. And we've seen private equity play a major role in rural health over the last few years. And there was a bipartisan effort to review that, which was not a charitable review. And so there may be some federal action in that space at the congressional level. So there's my contact info. I think I kept it under 35 if there was a 2-minute intro. Thanks, and I look forward to questions and any other feedback.
Thank you, Mark. That was that was an exciting, wild ride. It almost mirrors kind of what's happening with rural hospitals, right? Quickly moving target. I'm going to take the moderator's prerogative here and just ask a question that I put in the chat, just to kind of get your feedback. And I'm just sort of thinking about like what to do now. You know, I work with mentees who are interested in this area, and with budget cuts to CD public health monitoring efforts, would you expect a gap in information for rural health access, you know, to say whether, you know, we're writing a project proposal or whatever, right? Trying to get information. And then if so, if you anticipate a gap, are there other groups or other resources that can help us to establish best benchmarks or kind of figure out what's going on?
Yeah, this is a great and interesting question, and I think I'm going to address it in two parts. The first is that the CDC has launched an Office of Rural Health, and they've been pretty active, and they've taken a role much like the Federal Office of Rural Health Policy has at the in HHS, which is Section 711 of the Social Security Act creates the Federal Office of Rural Health Policy and charges them with advising, I think, the secretary on basically any rule and regulation that comes through HHS, which is an enormous task. And so they try and look at things that CMS is doing and offer, what would this look like in rural? And that's what the CDC Office of Rural Health perspective they've tried to take as well, so that when the CDC comes out with a vaccine plan, for example, at the tail end of COVID, the Office of Rural Health says, well, this is great, but when you talk about mass events in the parking lot of the NFL football stadium, that doesn't translate as well to rural communities. And let's think about what it would look like there. So there's been a lot of compendia, probably, or appendixes that office has offered on CDC guidance and best practices to say, and here's what it'll look like in rural, which I thought is a great move from that to think about that. Going forward, I think understanding what is the mission and of the CDC and its ability to fulfill that mission. I think one thing that we'll be thinking about, like disease outbreaks, for example, there, I suspect there will be some attention in of networks of providers. So for example, some states have a early warning or sentinel system, right, that can detect this kind of thing. Again, often built for anthrax or in response to anthrax, applied for COVID, but can be repurposed. And the ability to detect for example, measles outbreak in an urban area will be much easier based on numbers and connected IT systems, and for example, than it will be in rural. So I'm worried about that having the ability of rural areas to be able to be nimble and share information quickly for in response to things like that. That being said, rural often, if you think mother of necessity kind of language, it can be innovative, and so it may be that um, the ability to respond and identify new systems and to have a community meeting in a rural area says let's get 10 people at the hospital room after or the hospital boardroom after work tomorrow, and you've got yourself the core people there. So there will be differential levels of response that work best for their access. I don't know if I took a wide detour in response to your question there, Marta, but I hope it was somewhat responsive at least.
No, I mean, I was just, kind of keeping up peripherally about this measles outbreak in Texas, sort of thinking like, okay, if this happens again, when this happens again, like how can we mobilize a response? And are there other resources as well? Like, are there other groups that might also be helpful just to be aware of?
Yeah, I mean, I would think, often in times like this, like professional associations may step forward a little bit. So, I would imagine that would be there might be resources there as well.
Okay, thank you. Well, it looks like we are at time probably to pivot into our meet and greet, I believe. And I think we can just proceed. I don't think we have anybody that's on the call that we would have to peel away. So maybe we can just go ahead and launch right into the meet and greet. And maybe I'll let each of the UH faculty investigators introduce themselves briefly and then let you guys kind of go to it. So we've got Jennifer, Katie, and Abigail. No, I'm sorry. And Susan, my apologies.
I'm happy to introduce myself. My name is Katie Coyne. I am on our reproductive endocrinology and infertility faculty at UH. I also did my residency in obstetrics and gynecology, so I have particular interest in the closure of the rural L&Ds. But before I dive into my question, I do want to note, I think there was a question about how we can recruit physicians to these rural hospitals.
And it looks like he left. I don't
Okay.
see him, but I saw that, and I can send that to someone at I'll send that along, and then you all can get it to him, whatever.
Perfect. Well, I was curious about
I didn't see that until now. Appreciate it.
No problem. You had mentioned, Dr. Holmes, about targeted support for labor and deliveries in terms of Medicaid. I was just wondering if you think, or how likely do you think that is to actually happen to reopen L&Ds in these rural areas, or do you think that everyone will be shuttled into more main campus facilities for labor and delivery?
Can I just check if has the recording stopped? I don't see it, which means it probably has, but oh, there.